specifically dedicated to children. More generally, the treatment of vitiligo will include 3 types of treatments: topical therapies, phototherapy, oral steroids, and usually we use combination therapies, and I will tell you how we use them. Cosmetic camouflage is also part of the treatment of vitiligo, especially for very fair-skinned patients. So what are the factors associated with responsive treatment? Recent onset lesion. The more the lesion is recent, the more it is easy to treat. Facial lesions respond very well to treatment. Darker skin phototype respond better than fair skin phototype. Hand and feet lesions are very, very resistant to treatment, but you know that. You know that hand and feet is very difficult to repigment, probably because there is less hair follicles in these areas. What we do for stabilization treatment, if you are receiving a patient who has active spreading vitiligo, we try to stabilize them by using sequential oral steroids associated with narrowband UVB. What we do usually, we use oral dexamethasone, 2.5 milligrams per day on 2 consecutive days, and we give them after breakfast in a week. Repigmentation treatment will include sequential potent topical steroids, and don't hesitate to use potent topical steroids. What we do usually is that we say 1 week on and 1 week off to lower the side effects. Tacrolimus for the face, use tacrolimus for the face. It is more safe probably than topical steroids are. And there is a recent meta-analysis, I have not put this meta-analysis here, but it seems that tacrolimus is less associated with lymphoma than topical steroid. So all this discussion about tacrolimus for the moment is just a discussion. Excimer lamp and laser. Excimer laser is very expensive. It is very effective, but excimer lamp is as effective if you use it in a long period. It is more rapid with laser, but with lamp it works as well. Narrowband UVB or PUVA, I use almost exclusively now narrowband UVB. We use PUVA sometimes when you have no response with narrowband UVB, and especially for dark-skinned patients. But for fair skin, narrowband UVB is more safe for the eyes, because you do not have the association with the retinoids, but also for long term. It seems that narrowband UVB is less associated with skin cancer. And we use all the treatment in combination. So this is an algorithm to propose you how to treat. The first thing with the treatment is to avoid the triggering factors. This is the first step of the treatment. Then you search for the autoimmune diseases, in particular the association with autoimmune thyroiditis, which is the most frequent. You offer supportive psychotherapy if needed, in particular for adolescents. Offer camouflage counseling. We have in the clinic a nurse specifically dedicated for this, and it is very useful for the patients. If the disease is stable and the involvement is limited, we usually use topical treatment. If the disease is unstable, here we begin with oral minimal steroids plus MBUVB. When it is stable, we begin those therapy. This is just anecdotic to say that tacrolimus works well on the face, but it can work also on the body if you do it occlusive, with occlusion. But it is in reality, it's very difficult to do. Just a few cases of patients that we have treated and who have completely repigmented with tacrolimus here. For segmental vitiligo, exactly the same. The disease can be unstable, and this is, here you have the more chance to repigment your patients when you see him before the first cure of onset of segmental vitiligo. And if the disease is stable, you can do combination therapies, but usually you will go to surgical correction. But if you have your intervention at the time it is unstable, you will see that using this regimen, you can repigment the patients. And this paper has been published in the JAD last year, It's a retrospective study, but it's an interesting study done by our Korean colleagues. They had 159 patients with segmental vitiligo, all treated with the combination of 308 excimer laser, topical tacrolimus, and short-term systemic steroid. 50% achieved at least 75 repigmentation. So it is not true that segmental vitiligo do not respond well to treatment. And they looked for the factor associated with good response. It was disease duration longer than 12 months. This is associated with low response. Presence of poliosis was also associated with low response because the follicular reservoir is involved. Plurisegmental subtype is more difficult to treat. An independent prognostic factor of poor response. All of these were poor independent prognostic factor of poor response. Just to show you some picture of patients that I have treated in the clinic, and you can see that when I saw first this patient, she had trichrome lesions, so not completely the pigmented lesion. And we had a good result because only this was persistent, and you can see here that it was probably the areas that was more white. Another young girl that I have seen, but usually you need 1 year of treatment to achieve this. Also another boys that I have seen in the department. So what is expected in the future? I think that you will have heard about all of this. So what we do, we just published with Jerry Passon the study in the GID last year, where we did, like we do it in atopic dermatitis, a maintenance therapy with tacrolimus. So we try to evaluate the interest of a twice weekly, not twice a day, twice weekly application of topical tacrolimus ointment versus placebo in maintaining pigmentation in those patients who have been repigmented at more than 75%, whatever the treatment was. We randomized 35 patients, 16 were assigned to undergo placebo and 19 to undergo tacrolimus. 2 denied to continue for professional reasons, 2 were lost to follow-up, and 19 were analyzed. So we did an analysis, an intention to treat analysis. This is important because it shows how the study was strong. And here you have only 1 loss of follow-up. What were our results? 40% of lesions showed some depigmentation in the placebo group, 9.7% in the tacrolimus group. So 40% is what is expected in patients who have vitiligo. Usually you have 40% of relapse in the first year when you have completely repigmented the patient. And it was exactly what we found. But in the group that has tacrolimus, you only have 10% of patients who relapse it. And this was really something, we were waiting for something strong, but not as strong as this. So this treatment maybe should not be used in all the patients, but at least you can use it in those who have at least 1 relapse period in their life. You can treat them with a maintenance treatment twice a week. The problem is that our study was a 6-month study, and we don't know what happens after this 6-month study. The optimal duration is still to be determined. Just to show you this case report that has been published 1 year ago in JAMA Dermatology with tofacitinib. I think now you know that it is a JAK1/3 inhibitor. It was a woman in her 50s, vitiligo for 1 year, and she had, and this is important for me, she had oral tofacitinib only the half of the approved dosage of rheumatoid arthritis. So probably, we were discussing this with Raphael, probably that in vitiligo you don't need to have the same doses that you have in the other inflammatory diseases. 2 months of therapy, she showed partial repigmentation of the face and upper extremity, and at 5 months, near complete repigmentation of hands. The hands are the most difficult sites to repigment in vitiligo. You can see here in the exposed areas that it has completely repigmented, and the hands, it's fabulous. This picture are really nice. And this is another case where I think that he comes from your, no, it's not the studies that you have done. Okay, so John Harris published this patient of 35 years old who had alopecia areata since the age of 16, and several years he has vitiligo. The two diseases are commonly associated. I think that in my cohort, we have 10% who have both, vitiligo and alopecia areata. He was participating in a phase 2 open-label clinical trial with ruxolitinib. And you can see that he began to repigment. At week 12, there has the first evidence of skin repigmentation for his vitiligo. And you will see the pictures after. It's impressive how he repigmented, but what is more impressive is that when at the follow-up visit, 12 weeks after stopping the treatment, he depigmented. So probably that this treatment will need to be given in a continuous manner, at least in some patients, maybe not in all, but at least in some patients. And this is why it is important to lower the doses, because this medication has side effects, and serious side effects, so you can give them all life for a disease like vitiligo probably. So the conclusion is that childhood vitiligo differs from the adult onset vitiligo. You normally should screen allergic as well as autoimmune associated disorders. I do not hesitate to treat children, because the more early you treat them, and the best the results are. The differential diagnosis should be done, and the thyroid autoimmune disease are rare and only detected in non-segmental vitiligo. So if you have segmental vitiligo, you don't need to check for it. And I thank you.